Hello, I'm Jungyo, an assistant professor at Asa Medical Center. I'm honored to present our new clinical study published in Investigative and Clinical Urology entitled Efficacy and Safety of Low-Power HoLEP, a prospective, short and mid-term, single-blinded randomized trial. This investigation was led by Professor Seung-June of Seoul Regional University Hospital and was collaboratively conducted with myself and with Associate Professor Choo of Ural Medical Center. The surgical management of BPH is typically indicated in the case of refractory to medical therapy. Holmium laser enucleation of prostate HoLEP has emerged as the next standard of care in the surgical treatment of BPH. Conventionally, the energy setting of HoLEP ranges between 80 to 100 watt. However, hypothetically, reducing the energy level during HoLEP could confer advantages in the enhanced hemostasis and minimize risk to the urethral sphincter injury. An additional benefit of lowering power is reducing risk of mechanical failure of laser machine or fiber. Although the previous study have compared energy setting between 50 to 60 watt and 80 to 100 watt, there is a limited number of prospective study evaluating the setting below 50 watt. For this reason, we designed the prospective randomized control trial to assess the short and mid-term safety and efficacy of HoLEP performed at 28 watt compared with 80 watt. This study conducted between September 2020 to April 2021 at Seoul National University Hospital. Eligible participants included male patients aged 50 years or over who underwent HoLEP during the study period, and informed consent was obtained from all participants. Exclusion criteria of patients who with neuropathic condition that could adversely impact on low urinary tract symptoms. Additionally, individuals who had recently experienced the symptomatic UTI or acute urinary retention. The patients were stratified into two distinct cohorts via randomization. The low power cohort was subjected to HoLEP with 24 energy setting, while the high power cohort underwent a procedure with 80 watt energy setting. The primary efficacy endpoint of the study was defined as the IPSS score at the 6-month follow-up period. For the longitudinal analysis, IPSS was continuously measured at the 2 weeks time point after operation and 3 months after operation. Safety profile was evaluated through the Clavian-Dindo classification. We collected every adverse event from the operation intraoperatively and postoperative follow-up period. Here is the flowchart of the patient disposition for the study. On initial screening process, we evaluated 108 potential participants and 90 patients who met the eligibility criteria was subsequently randomized into the two study arms. The baseline characteristics of the study participants presented in this table. There was no difference between the age, comorbidity, preoperative PSA, and prostate volume between two groups. Intraoperative parameters were presented on this slide. Rising time was statistically significant longer in low power HoLEP group than high power HoLEP group. Total operation time, enucleation, and hemostasis time was also longer in low power HoLEP group. However, operation time was only 13 minutes longer in low power group than high power group. Total delivered energy was lower in low power group. The delivered energy of the low power group was 68% of high power group. The postoperative IPSS score significantly improved in both groups compared with preoperative IPSS. In both groups, IPSS total score continuously decreased until 6 months, and there was no significant difference at all time points at short, intermediate, and medium-term follow-ups between two groups. Storage symptom was improved more faster in low power group than high power group. IPS storage symptom score was statistically significantly improved in 2 weeks at 2 weeks in low power group, but not in high power group. The safety profile was compared between two groups. There was no intraoperative complications occurred with all of two groups. Intermediate postoperative complication was higher in high power group. However, there was no statistically significant difference between two groups. Mild degree SUI and urethral stricture occurred in one of each case in high power group. However, there was no SUI or stricture in low power group. In conclusion, HoLEP surgery using low power energy device with energy set lower than 30 watt provide comparative outcome with high power HoLEP. The storage symptom improvement was a little faster in low power HoLEP group than high power HoLEP group. Operation time was longer in low power HoLEP group. However, the mean difference is only 13 minutes. Low power HoLEP has benefit in less total delivered energy than high power HoLEP. This result means lesser possibility of mechanical failure of laser generator or fiber. Although there was no statistically significant difference between two groups, low power HoLEP group shows no event of SUI and stricture. Thank you for your attention.